This is the first time I am with you, PGS, sir. It's
Thank
great.
you. Thank you. Good evening. Good evening. Good evening. It's very pleasant that we can speak all the new speakers. Very good. I'm very happy. Thank you. Thank you. I think this meeting will be very, very casual. Don't worry. We'll just have it, our own personal experiences in this molecule. Yeah, it'll be better.
Sure.
So you are live, you can start now.
Yes, thank you. Sundaraman sir, shall we start, sir?
Definitely, definitely. Please.
Yes, sir. Good evening, doctors. On behalf of Alchem Laboratories, India's fifth largest pharmaceutical company, I'm Balaji. Take great pleasure in welcoming all the eminent doctors who have joined us for today's panel discussion. Doctor, today's panel discussion will be on vildagliptin, titled Views on Vildagliptin. Doctor, at Alchem, it has always been our endeavor to partner with healthcare professionals, and we will continue to do so even in these challenging times. To help us to navigate through the entire meeting, we have with us today senior eminent endocrinologist, Dr. PG Sundaraman sir, who will be our moderator for today's panel discussion. Welcome, Sundaraman sir, for this panel discussion. Let me take this opportunity to give a short introduction about our moderator, Dr. Sundaraman sir. Dr. Sundaraman sir is a senior consultant endocrinologist who is currently practicing at Bildroth Hospital and Apollo Hospital, Chennai. Doctor has got various credentials. He has got various publishing papers, 4 important publications under his name. And doctor is a senior consultant endocrinologist who is well known to all the doctors in Tamil Nadu. This short introduction, I welcome once again Dr. Sundaraman sir for this panel discussion. Welcome, sir. And let me take this opportunity to welcome all the eminent panelists who have joined us for today's panel discussion. And I'll take this opportunity to welcome every single panelist by giving a short introduction. Firstly, I'd like to welcome Dr. Selvapandian sir. Dr. Selvapandian sir is a senior consultant diabetologist who is currently practicing at Chennai. Doctor is director of Kamakshi Diabetes Care and Research Center, Chennai. Welcome, Selvapandian sir, for this panel discussion.
Yes, yes.
Let me take this opportunity to welcome the next panelist, Dr. K. Mohan sir. Dr. K. Mohan sir is a senior consultant physician and diabetologist who is practicing at MK Nursing Home, Chennai. Welcome, Mohan sir, for this panel discussion.
Thank you.
Let me take this opportunity to welcome the next panelist, Dr. N. Kannan sir. Dr. N. Kannan sir is a senior consultant diabetologist who is currently practicing at Chandra Diabetes Center, Chennai. Welcome, Kannan sir, for this panel discussion.
Thank you, Balaji.
We have with us today next panelist, Dr. Vijayalakshmi madam. Vijayalakshmi madam is a senior consultant diabetologist who is currently practicing at KM Specialty Center, Ashok Nagar, Chennai. Welcome, Vijayalakshmi ma'am, for this panel discussion. With this short introduction of panelists, let me hand over the session to our moderator. Sir, you can set the context for the meeting. Over to you, sir.
Thank you very much for your kind and well thought introduction. And dear colleagues and friends, at the outset, I wish to thank Alchem Laboratories for the pharma company to giving this opportunity to be before you, to be a moderator in this webinar session. In fact, it's quite interesting that it is a difference between RCT and real world study. The RCT is the Zoom meeting that we have. we have got a structured and we have got a predetermined setting up, and we have some, we have undergone the glitches and the various problems with the Zoom meeting. And the real world study is that where we talk directly to the audience. So it's quite interesting. So there is a lot of difference between the RCT and the real world study. To take you into the subject, a short introduction for the audience. In fact, diabetes is a puzzle like a cube. It's quite interesting that diabetes by the decades have gone into various shades, and each shade we understand more about diabetes, and every year in fact we get into know more new pharmacotherapy for this disease. In fact, it's a puzzle like a cube, and what is very unique in Indians, it is that the onset is quite early in age, and these Asians, especially the Indians, have a lower BMI, and they have evidence of ectopic fat accumulation. In fact, they have the altered structure of adipose tissue. Along with the sarcopenia, there is the, as you know, the triumvirate where there is resistance to the action of insulin. There is also a beta cell secretory defect, and there's a greater endogenous glucose production. This is very unique. And apart from the beta cell secretory defect, they have progressive defect in the incretins also. And there is a default in the signaling cascade for both beta and alpha cells. It is not only the endocrine function is going to be as disarray, but it is also the exocrine function. And along with that, the other hormones, such as they have exaggerated catecholamines, cortisol secretion, and inflammatory markers. Hitherto, we thought that the glucose is only the problem. But now we understood that it is not the glucose, it is more than that. It is beyond the glycemic events, the complications of diabetes. And this is because of the slower disposition of the glucose, and there is a mismatch of insulin secretion to the glucose load. That is why we now understand more why this complication occurs. And this is based upon the glycemic variability and the time and range, to mention a few. To bring the context very clear, as we are talking about the molecule, especially the vildagliptin, we want to know what is unique among the vildagliptin and what is the studies show the usefulness of combination with metformin, and not only with metformin, with other oral anti-diabetic medicine, and how this scores over other gliptins and its combination with insulin. And henceforth, as I told you, beyond the glycemic control, how far the indication is very appropriate in heart disease, liver disease, or renal disease. And we are not going to stop short with the people in the younger age group, but also how it is applicable in the elderly population. And finally, how this molecule becomes pocket friendly for the patient. Because once again, the compliance and the feasibility to buy the medicine is appropriate for our population, especially in India. Can you just project the first slide, please? Can you share the first slide? Yeah. So the discussion will be basically targeting on the verified trial, the H trial, and these aspects of the vildagliptin. So the first question, next slide, please. Next slide. Yeah, given the progressive nature, in fact, as you very well aware, the type 2 diabetes mellitus is progressive in nature. And you know very well that our population, the glycemic level is not achieved, the achieved amount of the glucose is not appropriate enough. So it becomes progressive. And many times we target only a monotherapy, and there is a long period of reluctance. And now, to make it very simple, I'll ask the audience, the panelists, especially Dr. Kannan, to tell us more about the verified trial, how it's applicable and how far it is going to be useful in our population.
Thank you very much, sir, for this wonderful opportunity. And thank you, my dear friends. Sir, this verified trial is based on the unique concept of so-called as the previous, the landmark trial, so-called as Euclides hypothesis. And also, this simulates the same pattern of ADOPT trial also, where rosiglitazone was compared with the other comparator molecule. Euclides clearly determined the concept of early intensification, going for the good glycemic legacy with metabolic memory and preventing the both micro and macroscopic complications. So the same pattern was applied in the verified trial also. Here, they tried with the vildagliptin with the early combination metformin in one arm. The other arm is nothing but the sequential approach. That is our traditional step care approach of metformin, then to the second drug, then to the third drug, then finding out the efficacy and safety and all. But what they have found that this is the real world setup study is verified is the important premium landmark study and comparing the UKPTS. This intensive glycemic control when comparing with the early combination of vildagliptin metformin with the sequential step care approach of metformin, then going for other things and all, they found with the two arm, they found as the outcomes of both two outcomes, primary outcome and second outcome. The primary outcome they found with the initial treatment failure with the end of the 6 months of the duration. 6 months, if the patient couldn't be able to find the HbA1c less than 7 in the 6 months, means in the early intensification combination like vildagliptin metformin, they have to wait for another more 6 months. They have to wait. Then only they are going for the second phase of treatment. But in the same study with the metformin sequential care approach, first they tried with the 1 gram to 2 grams of metformin. Then they stepped up the dosage with the combination vildagliptin. So they followed this step care approach. So what they found out in the early treatment, that is early intensification with the vildagliptin and metformin arm, shows the better glycemic control. Not only the better glycemic control, the treatment for the initial treatment failure was delayed by more than 3 years, and it is almost reduced by 42%. And more than that, in the secondary endpoint, they're able to find out, they're able to see the long-term durability, because we know that our type 2 diabetes is a progressive disease. Almost at the end of 5 years, totally 75% of beta cell will be exhausted. So with this early combination, we are not only seeing the glycemic efficacy, but also we are seeing the glycemic durability. And more than that, in the study, they have seen the exploratory endpoint regarding the CV outcome. In the CV outcome, they are able to find the numerical data and comparing with the sequential approach. So that is the main concept with this. So with the early combination with the vildagliptin metformin in the verified trial and comparing with the sequential approach with the step up, so that is loose dose approach, step care approach, they found out with the good glycemic efficacy, safety, tolerability, and more than that, they're able to see the glycemic legacy and metabolic memory for more than 5 years. Because this study was conducted for more than 5 years. With nil hypoglycemia, weight neutrality, good glycemic efficacy, safety have been achieved, and more than there was numerical significant benefit in the intensive arm and comparing with the sequential arm. Sir.
Yeah, it's quite interesting that Kannan was very specific and categorical that how the dual therapy, a combination therapy at the start of the diabetic onset, as you know very well, at the onset itself, around about 50% of the beta cells is not functioning, and where the intensification starts at the day 1 itself, so that we don't have the legacy effect. Now, I wish ask Dr. Mohan, what is real world study? How do you just, a lot of people, they have a reluctance because initially they start on the metformin and slowly wait for the things to happen. And in a real world setting, these are all randomized control trial. In a real world study, what do you think? will be appropriate for, it depends upon the glycemic level, or it depends upon HbA1c, or the patient profile, the clinical symptoms. What do you, how do you assess, and how do you start this combination therapy or monotherapy?
Thank you, sir. Thank you for the question. Let me start with thanking Dr. P.G. Sundaraman sir for this, for inviting me to this talk, and for the Blue Wilder people for giving us this podium. That said, we all need to realize that with the UKPDS, we are very clear that unless we reach the goal early stage there, we are going to build up a bad metabolic memory, that which is what we do not want. And unfortunately, Indians, though we spend less number of years in the impaired fasting or postprandial glucose status, we have early complications. So the time lag we have for somebody to get them under control is very little. So unless we are vehement enough to start with multiple drugs, because in reality, though there's a way in which you look at it, even though the precision medicine is more of a clinical medicine than real precision medicine. So you look at possibly the weight of a patient, possibly the HbA1c being less than 8.5, possibly the postprandial contribution, number of years of diabetes. So it is still a soft skill. So like, unless when we find that somebody is a diabetic, we go on all four to get them under control. The number of years they spend under control becomes lesser, number one. Second, the so-called sequential approach with most of the older drugs, we have seen that people, the drugs fail, the OHAs fail. There's a secondary failure of OHAs also has been a problem. The third thing is there is no way to tease out how a person is going to react to a particular drug. So unless we use more combinations at earlier status, is going to be very difficult. Accepted, it should be based upon the HbA1c more than 10, we say, like possibly even an insulin should be the starting point. HbA1c between and 8.5 to 10, you may need multiple drugs. But then still I feel that we should start with multiple drugs even to start with, unless there's a scare of hypoglycemia or old age where your hypoglycemia can land them in trouble. Okay, any age where hypoglycemia could land them in trouble. I would always love to start with a multi-drug regimen, so that the achievement is much easier, much smoother. Number of years they continue to achieve such a result is much better. The idea of our entire treatment in the real world is to prevent complications, it's not number chasing. So like for that to happen, unless we achieve it early, fast, without hypoglycemic events or weight gain or other side effects, it's not going to be useful. So in the real world setting, I think all of us agree that it should be a much faster approach to reach the goal much faster.
Can I have the next slide, please? Yeah, it is very correct that Dr. Mohan was categorical that it is going to be a patient-centric approach, and he said that hit the target early so that you can prevent the complications, which is beyond the glycemic control. I call upon Dr. Selvapandian to just give a brief overview about the EDGE study and how is it applicable in the real world data.
Thank you very much, sir, for this kind of opportunity, and I thank Alkem people also for this excellent opportunity. And EDGE study, I was part of this EDGE study. I was also doing this study, and it was an excellent study. It was a large study where it was being conducted in all throughout India, and wherein we saw the combination effects of different drugs with vildagliptin. So I used to call DPP-4 as a joker card because it fits in with each and every OHS or even in the insulin also. And the effect is really beneficial for the patient, because if you add on to a sulfonylurea, when sulfonylurea is given as a monotherapy, the hypoglycemic risk is more. But when you add it on to a vildagliptin, the hypoglycemic risk also comes down. And when you add on with your metformin again, the synergistic effect is more, the HbA1c reduction will be more. And same thing with the insulin also, the hypoglycemia risk is less. And even you can bring down the dosage of insulin. And now there is an excellent combination, SGLT2. because in SGLT2 the endogenous hepatic glucose output is more, which has been taken by the alpha glucagon suppression. Thereby your endogenous glucose output has also been reduced. So the synergy system works very well. Now this SGLT2 and DPP combination is a very good combination, because all the side effects have been converted into benefits, and like that each and every molecule with your vildagliptin or the DPP-4 inhibitor has a very good synergistic effect. And as the other speakers have been telling, the benefits are the risk in weight gain is been reduced, and the glycemic durability is also increased, as Dr. Kannan was talking about the VERIFY trial, because before, when you have been using as monotherapy, the failures were much earlier, so the combination therapy was better. So any combination, if you combine with sulfonylurea, again the combination is going to be superb. And again, when you combine metformin, vildagliptin, and sulfonylurea, this triple drug combination also works very well. And all the side effects like your weight neutrality, I think hypoglycemia, everything comes down, and very much suitable for any age, and the risk of cardiovascular benefit is also neutral here. The risk of side effect is very much reduced with this combination, and synergism also increases with this combination.
Yeah, it's very interesting that Dr. Sallapani has highlighted that the drug neutrality and how it's very effective in not only causing less weight gain, and evidence of hypoglycemia is lesser, and how triple drug, when already the patient is on an insulin or a secretagogue, where you add on with the vildagliptin, it has got a synergistic effect, and also it causes the reduction in the dose of insulin, especially when there is a combination with it. I call upon Dr. Pradeep that why you pick up vildagliptin over other gliptins, and how far in your real world study that you have seen it's more useful compared to the.
Yeah. Thank you so much for this opportunity. And like the real world also reflects what we saw in the study, in that vildagliptin in combination with any other OAD seems to show better overall clinical benefit than any other two-agent combination. In real world too, we see this, that the we get better A1C reduction and better tolerability as well. There's less peripheral edema, there's less weight gain, and less hypoglycemia, as mentioned by all the other panelists as well. And this is seen as in the real world setting too. So whichever drug we choose to add on to, it seems to be better than any other single combination of drugs. So this real world reflects the data we got from the EDGE study as well.
Yeah, it's very true that the durability and the HbA1c reduction was better when you put on a twice daily vildagliptin along with the other medication. The next slide, please. Yeah, I call upon Dr. Vijayalakshmi to have a brief overview about when you have already triple drug therapy, what is the ideal triple drug therapy that in your real world setting will be there for you when you're having a triple drug therapy? Dr. Vijayalakshmi.
Thank you, sir. Thank you for the opportunity, and I would like to thank all the other panel members also for their excellent inputs to this today's evening's discussion. So, as my previous speakers and yourself have summarized already, we all know that maintaining a target HbA1c of 6.5 to 7% is very important for our patients, so that they can prevent long-term complications, both microvascular and macrovascular complications. To start off with, we would obviously try to reinforce lifestyle modification for any patient, and to add on with that, metformin will be the first choice of agent. And in an Indian setting, most of our patients, I'm sure all of us would agree that around 80% of our patients would be on some kind of sulfonylurea. And the ideal sulfonylurea would be a second generation, the new generation sulfonylurea, which has a more glucose sparing effect, and we tend to avoid the old generation sulfonylureas which have a higher affinity for binding and slow dissociation rates to avoid hypoglycemia in our patients. So with the background of metformin and sulfonylurea, a DPP-4 inhibitor would be a welcome add-on to the patient, because when we just try to increase the sulfonylurea dose and achieve our target levels, then the patient will probably go into hypoglycemia, which happens in most of our patients when we titrate only with increasing the dose of sulfonylurea. Because DPP-4 works through the incretin pathway, it kind of helps the patient achieve the HbA1c targets post fasting and postprandial without causing any undue hypoglycemia, and therefore it also reduces the effect of weight gain that is seen in patients who are only on sulfonylurea and metformin. Therefore, in my practice, a combination of metformin, sulfonylurea, and DPP-4 inhibitors are very common.
Your audio is not clear. Your audio is not clear.
Sorry, I think am I audible now, sir?
Yes.
Okay. So I think in an Indian setting where cost consideration is always paramount importance, so the most common combination, triple drug combination that's used is the combination of metformin, sulfonylurea, and vildagliptin. But now that just like DPP-4 inhibitors, even the SGLT2 inhibitors also gone off the high cost mark, and it's become more affordable and pocket friendly to the patient. So in that case, a combination of DPP-4 inhibitors and SGLT2 inhibitors along with metformin is also a very ideal patient, because as we all know, SGLT2 inhibitors work through by inhibiting the reabsorption of glucose. But what happens is, over a period of time, it is seen that the glycosuria that initially helps a patient to achieve a good glycemic control is offset by increased endogenous glucose production that happens. So therefore, a combination of SGLT2 inhibitor with DPP-4 inhibitors kind of helps them reduce this endogenous glucose production, because DPP-4 inhibitors acts through the glucagon axis. It reduces the glucagon oversynthesis. Therefore, the endogenous glucose production is also reduced. And this combination of SGLT2 inhibitors and DPP-4 inhibitors also has been shown to be more effective in Asian population when compared to the Caucasian population. There were comparative studies which has shown that both SGLT2 inhibitors and DPP-4 inhibitors work better in Asian population when compared to Caucasian population. So therefore, a combination of metformin, SGLT2 inhibitor, and DPP-4 inhibitors would be very ideal for a patient to achieve a good glycemic control without causing hypoglycemia and weight gain. But if the cost factor is a huge issue, then sulfonylurea would be more effective.
Yeah, you're quite correct that the importance of the endogenous glucose production, and also the mitochondrial effect of increasing the cyclic AMP and ATP in the liver, and how the SGLT2 inhibitor has got a synergistic effect when there is hypoglycemia, where it has an effect on the glucagon. And also, you were also categorical that the molecule as such, like the DPP-4 inhibitors and the SGLT2, is an ideal suit for the Asians, especially the Indians, compared to the Caucasians. And it's also interesting that the pharmacokinetics, there is the 4 pathways, the metabolism for the especially the vildagliptin, and that the scores over the other molecules in the form of drug interaction is also less with the vildagliptin. Next slide, please. Okay, now you have the cases where you find that there is an inadequate glycemic control, and in a combination therapy, when you have a triple drug therapy. How do you balance it? How do you, which drug you will reduce, which drug will increase, whether you'll increase metformin or sulfonylurea or the gliptin? What is the real world study? Dr. Kannan, I want your opinion, please.
So already our Dr. Sarvapalli clearly mentioned the importance of H trial, sir. But in the same H trial, they did another important outcome analysis, so-called as H post hoc analysis. There they have tried, even with the patient couldn't be able to tolerate the metformin, because most of the Indian patients couldn't be able to tolerate metformin. They are very sensitive metformin. So in the absence of metformin, they tried as a real world scenario in a routine clinic setup that this vildagliptin and combined with sulfonylurea or any other drugs and active compared with other OADs, they're able to find the good HbA1c or long-term durability with the vildagliptin arm and comparing with the other OAD arm. And more than that, the durability pattern are also well established. But the more apprehensive thing regarding with the combination therapy has been mostly satisfied with the Vilda combination with the sulfonylurea and combination with metformin, because we know that type 2 diabetes is a progressive disease. But after the duration of 5 years or 6 years, almost 70 to 80% beta cell will excel. So if they couldn't be able to even to have the good glycemic control, even with the 3 drugs or 4 drugs, then the key role will be the last choice will be the insulin, because insulin is the final reserve. Insulin is the trump card of the management of the type 2 diabetes. So vildagliptin with metformin with the sulfonylurea is one of the good combination for Indian context, because it is very, very cost effective. And we know that in a routine clinical setup, almost 70 to 80% of the population are receiving metformin with the sulfonylurea. So with the top up with the vildagliptin, we'll have the good glycemic control, good efficacy also, good durability have been clearly proved by Milner, Carolina and Carolina also. So these combinations will be very, very helpful and one per combining with the other combinations, sir.
Yeah, you're very correct that it depends upon the HbA1c, whether it is more than 8 or less than 8, and what is the fasting glucose level, and how far the duration of diabetes. In fact, as you are very well categorically told, that it is a progressive beta cell defect, and where you need addition of a secretagogue at one point of time. Dr. Mohan, next slide, please. Now, in the setting of reduced renal function, where you require adequate glycemic control, how far the vildagliptin have a role in maintaining the good glycemic control, and how you are going to titrate these patients, and what are the main criteria that you're going to go through?
Thank you for the question, sir. I mean, I'll start the opening gambit saying that we need in renal dysfunction 2 problems that we generally face. Most patients would go on insulin because most of the treatment therapies are either incapable of maintaining and very solid time and range sort of picture, which is absolutely necessary for us to give them any reduction in their progressive failing renals. Better glycemic control on long-term benefit has clearly shown, at least the real world, we have seen that early on, if you give them better glycemic control, there are a lot of patients who have got a higher creatinine who normalize over time. So given a good control becomes very, very important, for which many drugs in a higher creatinine setting are contraindicated, so they may need insulin. That said, these drugs have been a lifesaver there because they do not cause metabolites, but they work at a lower dosage. So they are not directly toxic to the kidneys. Sulfonylureas have their own bag of problems. You may not initiate them. Some people say you can continue if they are on glycoside, other drugs, or glipizide. Some people say glipizide. But rarely you will be in a frame of mind to continue in a real renal patient because of chance of hypoglycemia and other things. Ultra short acting sulfonylureas, yes, possibly, yes, but still, like, it has got its own set of the thing. Again, you would not use them in real renal dysfunction. So, like metformin, you would not initiate. You may continue till they come to around 30, then stage 4, you start tapering or stopping. So the choices are very little. The plus point with these drugs are at a lower dosage. The dosage is because they work better even with a lower dosage. That's all. They are not really toxic to the kidneys. So the plus point of these drugs are that even with lower dosage, you'll be able to give them the benefit. Number one. Number two, these by themselves do not cause weight gain. They do not cause hypoglycemia. So the chances of giving a much smoother control is much better. These drugs are one of those set of drugs which works on multiple levels of the thing, on the satiety center, at the gut. It stimulates the pancreas. So like it works on multiple levels. Thereby we are able to touch the multiple pathologies which just occur more during a person with an renal dysfunction. So that way around, these drugs are very, very, very easy to use and much easier to titrate. Yes, accepted Lina, people have always said that DAS is a drug which need not go unchanged. But we need to understand that other drugs work at a lower level, at a lower dosage. So possibly it is more, it is cheaper for a patient to continue and drug at a lower dosage than at the full dosage. So like I find that as a this thing. So seems to be a very good drug to continue during renal dysfunction. So those are my thoughts.
Yeah, everything depends upon the EGFR, and
Yes.
Whether you're very correct that people who are having a 60 or people who are having 30, and you know very well that it is not only the glycemia, especially in a renal disorder, you have other associations like acidosis, electrolyte imbalances, azotemia, and already the patient due to azotemia may have the various clinical implications like nausea, vomiting, or so many parameters are involved. And it depends upon, as you are correctly told, it becomes a patient-centric. Now, I'll require Dr. Selva Pandian to give his brief overview, especially in a setting where, in a real-world setting, if a person is having a GFR less than 30, who has a moderate HbA1c around, say, 7.5. Now, what is your approach in this case? Whether you will continue vildagliptin or you switch over to insulin, or what you will do in a real world setting?
Yeah, sure, sir. Because already the EGFR has come down below 30. It is better to be on insulin. But with insulin, the problem is frequent hypoglycemias and other things will be there. To conquer that, we can use gliptin. And gliptin also, with vildagliptin, one-step reduction only we have. Whereas with the sitagliptin, we have to go for two-step reduction. And there are some gliptins where you not change the dose. But with vildagliptin, one-step reduction itself, as Mohan was talking, it is not having any nephrotoxicity. The mean inventory concentration with the half the dosage is enough for the control. And there are studies where with different EGFR they studied, and in all the levels of EGFR, the HbA1c reduction was very good, because that is the important thing in the control of glucose. So at all levels, the efficacy was well. Even at in the elderly, it was very fine. So using a gliptin where your insulin and hypoglycemias and other trouble, so in that case certainly your gliptins are going to help you. And there are enough evidences also to show that these thing reaches the target very easily without much of hypoglycemias and weight gain. So
yeah, yeah.
This can be the usage of gliptin when we have trouble with the hello.
Yeah, please.
No, this is my thought, sir.
Yeah, you're very correct that the main problem with the renal disease is hypoglycemia, and whether you're going to use a secretagogue or insulin, everything requires very tight titration. And here in this case, there are studies which have shown at the various shades of GFR, the usage of vildagliptin at a lower dose, titrated doses, has definitely shown a benefit on the HbA1c reduction. And so it can be an add-on therapy, especially in a diabetic with renal disease. Next slide, please. Now, it is not only the youngsters, but elderly population also require a tighter control. And how far will vildagliptin will be an answer for this, especially when it is now I want Dr. Pradeep to first highlight and which group that you say is a geriatric group, and how far you're going to approach these patients. Dr. Pradeep, please. Dr. Pradeep? Is there Dr. Pradeep?
Sir, Pradeep sir got disconnected.
Yeah, I think
Pradeep is not in the yes.
Oh, okay. Can I call Dr. Vijay Lakshmi, please? Dr. Vijay Lakshmi? Dr. Vijay Lakshmi? Okay, without wasting time, I call upon Dr. Kannan to give his comments on which group that you just say it's a geriatric group, and now they say that the 60 is not old age, it is around 65, and the most old is more than 80 years, and how far that this molecule is applicable to this population.
Thank you, sir. Thank you for the opportunity, sir. Once again, sir, in our routine clinical setup, the most challenging and crucial issue among the diabetic patient is managing the elderly population, sir, because elderly population that doesn't have only diabetes, they have other comorbidities like they are associated with hypertension. Most of the diabetic patients with the elderly population have heart failure, they have kidney disease, and more than that, sir, their frailty and the CV burden will be there, some renal burden, congestive cardiac failure, and cognitive behavioral disorder, polypharmacy. These are the most crucial challenging phenomenon in the elderly population in the management of type 2 diabetes. In this setup, sir, so routinely in routine clinical practice, we prefer metformin as the early drug for the elderly patient, because metformin is neutrality, no hypoglycemia and all, one of the safest molecules. The only thing we have to keep in mind regarding serum creatinine level and also estimating this one's ventricular function, because ejection fraction less than 40, metformin is strictly contraindicated. Any patient will have any COPD or any bronchitis, any respiratory hypoxia, this metformin is contraindicated. So these are the things to be kept in mind. So in elderly patient also, the things should be individualized. And more than that, the HbA1c relaxation should be given for the elderly patient, because most of the elderly patient, the duration of diabetes are more than 10 years or 15 years. Invariably, they're having a hypoglycemic unawareness, because most of the elderly subjects will have some autonomic sympathetic activity dysregulations, and therefore they're more predominant for the hypoglycemia unawareness. These have been kept in mind. We have to postulate the treatment according to that. So low dose of metformin can be given, or glycoside or MR form can be given, or if they couldn't be able to tolerate the glycoside, maybe we can prefer vildagliptin, because vildagliptin is this one half-life is only 4 to 5 hours, so safely can be given in the low dose like 25 milligram BD can be given, sir. This is my thought and my concept, sir.
Yeah, once again, you're very correct that it is not only the glycemia, their mobilization is poor, their cognitive apparatus is poor, and their compliance is poor. And you are very correct that we need a fixed dose combination pills where you aggregate most of the pills, and so that the compliance also increases to a very great extent. But especially when you have beyond the glycemic control, you have got other comorbidities. I asked Dr. Mohan that how will you approach these cases, especially diabetic population, with this elderly patients with other comorbid situations?
Yes. One of the commonest, like more than real comorbidities, three common problems we find with elderly patients is one is complaints because they have a lot of gastritis, they have a lot of gastric issues. So many of them, those who are tolerating metformin also suddenly seem to have trouble with metformin. That is something I do find. Like as the comorbidities increase, like physical comorbidities in terms of swallowing, all those things increases, more complex regimens become difficult. So this combination pill seems to be a very good answer for that on one side. On the opposite side, when they have other comorbidities like renal, which we already talked about, hepatic, when we have congestive cardiac failure, in a place like India, like a lot of them are absolutely resistant to take insulin even at that time. There, these sort of softer combination pills like like a lower dose of an DPP-4 inhibitor, possibly voglibose, possibly a very small dose of sulfonylureas, seems to be the only answer we have for those people, because like many of them are dependent, they are not ready to take insulin. Many of them have multiple comorbidities where you do not want to cause hypoglycemia. At least if they have a mild disease, I think the DPP-4s are an excellent answer, because like it stimulates the pancreas, seems to have a very good the thing, though they are generally weaker molecules by themselves, they rarely have other side effects at all. So that way around, in an elderly population, seems to be a very, very good set of drugs. That's my take on it.
Yeah, there's a lot of problems with metformin, as you correctly told that, especially the immediate release. I think it must be out of the market. We now use one extended release, and those who are able to tolerate also, they are not able to tolerate. And it is also a similar case with the voglibose and carabose. Sometimes they have very serious side effects. I asked Dr. Selvapandian, what is real world studies or experience
sir,
on?
Can I just interlude, sir?
Yeah.
Like I would like to place the same question to all the panelists. Like in my practice, somehow even people who have been tolerated voglibose for a long time, suddenly after they have a gastritis due to some other reason, they go on NSAID, they have a gastritis. After that, they don't tolerate. Does it happen in everybody's practice, or is it something
in my experience, it happens. Yeah, I can ask the panelist and please.
Very common movement that is.
Sorry to interrupt.
Yeah.
Yeah, it's quite common.
Yeah.
Dr. Selvapandian, Selvapandian, what is your views on the combination with SGLT2 inhibitor and DPP-4, especially in elderly population?
Really a very good question, sir. Thank you for that. I think in the elderly, even though SGLT2 been a wonder molecule in diabetes, but in the elderly, certainly already they have some I think comorbid like hypertension, some diuretics they will be taking for the heart failure and other things and all. So, and they will be prone for frequent, especially females will be prone for higher urinary tract infection, genital infections. Same thing in the male also, because first of all, their food intake comes down, water intake comes down, and already if they have any renal insufficiency, again the liquid part will be reduced again. So with all these things, I think so. SGLT2 will be very, very selective with less comorbidities, and if the renal function is fine and if the immune system is good, then only I think so. SGLT2. Otherwise, DPP-4 will be a very suitable drug for an elderly, because it does not cause hypoglycemia, and I think gastric symptoms are very less, and weight gain is also not there, and satiety also will be achieved. So multiple benefits with DPP-4. Certainly a very good combination, but in the elderly, you have to be very cautious, especially in females with SGLT2, with frequent UTI and genital infections. You should be very cautious. And we have a general recommendation also, below EGFR of 45, it is better not to use SGLT2 because enough nephrons will not be there. And although there are studies which are going on in people with less than EGFR of 45 or 30 also, will be knowing the results in the next couple of years. But still, I think so. It's a very tough challenge using DPP4 and SGLT2 in an elderly geriatric population. Whereas in the middle age, certainly it will give a lot of benefits, and it has got a lot of cardiovascular benefits rather than hyperglycemic benefits. Again, as you told, it has to be very much individualized. I think only a small subgroup can be fit into this combination of DPP4 and SGLT2 in the elderly. Otherwise, it is very difficult, except even as Dr. Mohan was saying, even Voglibos or Metformin also, I think now SGLT2 can be started even with without starting Metformin. So in that scenario, DPP4s are the best drugs in the elderly, and because it requires less monitoring and durability and glycemic variability, everything has been taken care. And even in renal insufficient patients also, this is going to be a boon with the appropriate dosage. So this is my opinion, sir.
Yeah, there is an elegant study on the single nephron, the nephron unit and beta cell unit. These two things are decreasing with the age, with the increasing duration of diabetes. And you are very specific because of the more incidence of electrolyte imbalances, and the hydration is not adequate enough, and other comorbid like prostatomegaly with residual urinary infection. SGLT2 inhibitors, it must be careful. Whereas in the DPP4 inhibitor, it's a very well useful molecule, especially in the geriatric population. Next slide, please. So can I have Dr. Pradeep? How do you see vildagliptin versus other gliptins? Dr. Pradeep is there?
I don't think it's connected.
Okay, Dr. Vijay Lakshmi.
Yes, sir.
Please, can you comment on this? How do you see how vildagliptin scores over other gliptin, and what is your take-home message that now the 100 milligrams vildagliptin has come into the market, single dose, and how far it is useful compared to the BD dose? Your comments, please.
First, to go with the 100 milligram once daily, first thing is anything that we give once daily improves the compliance of the patient. So that is one thing that may be helpful to the patient. But we have to be a little cautious here, because vildagliptin 100 milligram, first of all, there are studies with very few numbers again, where they have recorded some kind of ECG abnormalities with 100 milligrams. So there is very few and small scale studies. So we have to wait, because vildagliptin per se has not come up with any robust cardiac safety data. So with 100 milligram OD, especially, as far as 50 milligram twice daily, then it can be safely given. So when before we jump on to the 100 milligram OD bandwagon, we have to be little use it in caution, with especially in the elderly population and all that. To answer your previous question, comparing this vildagliptin with other gliptins, as we all know, they are the same group of medicines, but the pharmacokinetics and dynamics vary between the different vildagliptins, different DPP4 inhibitors. And the vildagliptin seems to have more affinity towards DPP4 inhibition, the receptor. So therefore, the glycemic efficacy also seems to be, the potency of glycemic effect seems to be favoring the vildagliptin compared to sitagliptin, which is there widely available. But again, we don't have direct huge data on head-to-head comparison with other gliptins. But I think from our clinical practice, we can safely say that vildagliptin definitely scores over other gliptins in terms of better glycemic control. But whether we can completely change over from twice daily 50 milligram to safely to 100 mg is something that we need to wait and watch, and then make the transition a little slower based on the evidence that is going to come out.
Yeah, you're correct that there were studies of the effect of vilda single dose on the cardiac failure data and the ECG data, and I need more robust study on the single dose therapy, and also the effect of the pharmacokinetics, which plays a greater role in vildagliptin in the form of affinity and the HbA1c reduction and other parameters, especially in the endogenous glucose production. All that pins over more in favor of vildagliptin. Can I have the next slide, please? So the pocket friendly. Now, how you know very well that when there's a flood of market where you have increased medicines coming with vildagliptin, and what is your take-home message? Can I ask Dr. Mohan about his comment, please?
Yes, sir. See, I do understand that it has become cheaper, but there's been a slew of number of the thing which has come in. But even with what I had always felt was, even at its original cost, the gliptins were wonder molecules, because like they prevented, just like we calculate for insulin, like they prevented hypoglycemia. They had multiple effects. They were lasting longer, so titration was not a problem. Unlike sulfonylureas, where self SMBGs, so many numbers need to be done. That cost is much cheaper. So it has been in value proposition through and through, even prior to this, the drugs becoming, generic drugs becoming available in reality. But that having become available, I think it's become much easier for everybody to have the plus point of these molecules. Because like there have been times when there have been few patients whom I have started the original vildagliptin with the thing. Still, they are on twice a day vildagliptin metformin for the past 10 to 12 years. So that does seem to occur. So with the price, the thing, and it's a very good molecule, I think it's only right that more number of people get this at the end of the day.
Dr. Kannan, I just want your opinion on a person who is already on one set of innovative brands. Will you switch on to the other brands and in a real world setting when it's well controlled, or just because the drug is cheaper?
Yes, sir. Thank you, sir. So if you see, sir, in our routine Indian context, we are well empowered from landmark study and ICR INDAP study. In both the study, among the interim analysis, they're able to find that only 15% of the population have the effective HbA1c control less than 7, and more than 70% of the population have HbA1c more than 8.5 to 9. What is the reason, sir? Is unawareness is one of the key factors, but more than that, cost factor also is one of the important, because accessibility, affordability, availability is one of the main emerging thing for the management of type 2 diabetes in the Indian context. And more than all the diabetic societies across the world, like ADA, EDF and all, if you see all the algorithm, the cost is the issue. Cost is the factor have been clearly included, sir. In our RSSD also, they are segregated according to the platform like A, B, C, D, E approach. In that thing, the C is the cost factor. So cost factor, apart from comorbid factor, cost factor also should be clearly implemented. And more than that, 70% of the Indian populations are spending their money from their own pocket. So affordability is one of the key role in the management of type 2 diabetes. So if a drug is available in the cheaper cost mean, it will reach in all class of patients, so that the patient friendly will be there, and also the patient will control the regimen properly, and ultimately they have better glycemic control. By the better glycemic control, they will enjoy the benefit of glycemic happiness. This glycemic happiness will have the long-term benefit regarding in preventing both the micro and macro complications. So cost factor is very, very important for the Indian class of patients.
Yeah, it's important that the cost is very important, because many times the people miss the dose because of the cost factor, and the also the compliance and accessibility and availability is very, very important. The studies have shown that just giving a prescription, it doesn't matter much. It is the patient taking it is very important. Dr. Selpanin, this is out of the box. That
yes, sir.
Now we have shown most of the studies are with metformin. What is your personal experience of using vildagliptin in the pioglitazone?
Thank you for that question, sir. Certainly, sir, it's a very good combination to say. Pioglitazone, a molecule which acts at the nuclear level, and it has shown the I think MACE reduction also. I think stroke reduction is also seen with the pioglitazone. But except the heart failure and the water retaining effects, I think so pioglitazone is a very good molecule, and especially when you're combining with the DP4 inhibitor, I think again the synergism here also, the weight gain because of pioglitazone can be negated with your DP4 inhibitor like vildagliptin or something like that. So this combination, and again it has to be judiciously used, and it has to be selectively certain population where they don't have any heart failure or any cancer and other things should not be there. Any comorbid like this should be avoided. Recurrent fractures and other things in females. So these type of individuals has to be avoided, and then it has to be used. But it needs more monitoring, sir. If you are going to monitor the patient frequently, I think so. On their weight gain things, certainly this has a very good thing because it has both they attain most of the pathophysiological features, and certainly so this combination is a wonderful combination if it is used judiciously, sir. And as I said, avoiding in patients who are having recurrent fractures or any cancers, pancreatitis and other things and all, it's better to be avoided. Otherwise, a very good combination, but again it has to be very, very judiciously selected. Patients has to be used, sir.
Yeah, many times
you,
I find problems with metformin and oglibos. I personally have started with the pioglitazone. And another important thing is that it's quite useful in steatohepatitis, where fatty liver, where pioglitazone is also another indication.
Really?
Dr. Pradeep is there? He is not to be seen. Dr. Vijayalakshmi, what is your opinion on this molecule which has flooded the market, and how you will grade these molecules? It's a very difficult question. Which type of gliptin you will choose? Dr. Vijayalakshmi? Sorry, they are not, I think. Dr. Kannan?
Okay, sir.
Sir? Yes, sir. Yes,
Yeah.
sir. Yes, sir. So since 2008, we are enjoying a lot of gliptins, sir. We are experienced the sitagliptin, then the Saxa, then Lina, then vildagliptin, then we are in the era of teneligliptin also. Regarding with the glycemic efficacy part, all the gliptins are the same HbA1c reduction between 0.6 to 0.8. So the only thing we have to see in the CV outcome, but CV outcome at par, all the gliptins have the excellent CV outcome in neutrality, except the Saxa have the highest signal for the this one, sir, heart failure signaling. But regarding with Vilda is a unique property of giving 2 times a day molecule. But on comparing the other gliptin, the vildagliptin now show the excellent benefit on reducing the MAGE reduction, because they are conducted a Japanese study with 33 patients in 2 years back. They found out with the vildagliptin, even with the 2 times a day or once body with 100 milligram, they're able to find with the excellent reduction in the MAGE excursion, that is mean amplitude glucose excursions, by means of reducing the glycemic variability. And this glycemic variability is one of the markers for the oxidative stress and bringing the benefits on both micro and macro complications, sir. This is one of the important things have been highlighted by various trial models. So even though all the gliptins are very good, same CV neutrality, then no hypoglycemia, is friendly, and also gives all the benefit regarding the things also. But the glycemic variability part is somewhat lesser with the vildagliptin and comparing with the other gliptins. But it is exclusive for the linagliptin, because linagliptin is one of the important gliptin. It's known as the autopilot mode gliptin. It can be given in all class of patients, like end-stage renal disease, end-stage hepatic disease. Any class of patient can be received the linagliptin port. But comparing the other gliptins, first place can be given for vildagliptin, and second given for Lina, and third I can prefer for the sitagliptin, sir. But regarding the cost factor, I prefer only vildagliptin for Indian context of patients, sir.
Okay, I request Dr. Mohan and Dr. Silapani to give their final comments on this molecule, please.
Yes, sir.
Sir, as we have already said, possibly as Dr. Selvapandian always says, a beautiful word for people to remember that this is like a joker card. It's got beautiful synergy starting from metformin to all the drugs. Every drug has got its own place in the armamentarium. Yes, we have been talking about cardiac side effects, we have been talking about other things. But we need to remember DPP-4 in general are cardiac neutral. They're quite cardiac safe with all the muscling and whatever said, they are all very cardiac safe. It acts in multiple places of the omnious octet. So these are drugs which have shown, we got a track record of almost 20 years and almost 15 years, more than a decade of experience with these drugs, and they've been very, very nice generally. So now that it's become affordable, a lot of people should go on. We need to understand that we need multiple drugs to start with itself. So we no more advocate the step care approach and drugs which do not cause hypoglycemia, so which is a big plus point. I think we should start adding those drugs which do not cause hypoglycemia and do not cause side effects like weight gain and all those things. But we need multiple drugs to start with early and keep them under control, for which I think the cost reduced will as a boon now.
Dr. Sellapanian, please.
Yes, sir. Sir, I think this combination, that is vildagliptin with metformin, is cheaper than your sulfonylurea and metformin in many ways. And it is such a molecule, we can say like this Honda thing advertisement, fill it, shut it, and forget it. So like that, when you start it, your monitoring also comes down. You need not monitor frequently, like your sulfonylurea, metformin, your weight gain will not be there. Even saxagliptin in the Savior trial, I will say the patient selection was different. That's what we had some increase. Otherwise, saxagliptin also was a beautiful molecule because we experienced a very good glycemic reduction. So anyhow, because of the study, we have neglected that. But still, this combination is the #1 combination in the diabetic prescription now. Even though sulfonylureas have come down, only 25% of the prescription is sulfonylurea. I think most of the prescriptions now are with this vildagliptin and metformin. Even general practitioners prefer this because they need not worry about hypoglycemia, weight gain, and as Mohan was telling, cardiac neutrality, everything is there. So I think so. This and it is cheaper also now. And if you are going to start in a drug-naive patient, certainly the benefits are going to be seen very much in the drug-naive patients when you are going to use this fixed dose combination. So I will say this has changed the diabetic management in the past 15 years with DPP-4 inhibitors, and now it has come cheap. The patency is gone, and I think so. This is a very good combination. You can just forget, prescribe, and just forget about the thing. Certainly, nothing is going to happen to the patient. That so many things are going to be taken. It has multiple pathophysiological factors. It corrects. So in that scenario, I think so. This is a boon for the Indian patients, especially for the Indian Asian patients, for the cost factor, and a very good drug to start in a drug-naive patient, fixed dose combination of vildagliptin and metformin. This is my thoughts, sir.
Yeah, you're very correct. Just like an Ambassador car and a Maruti car, when we had Ambassador, we used to monitor it very frequently for the radiator water, the tire, the engine, everything. Now Maruti, the change has come where you didn't monitor, you didn't fill up the water, or and if you didn't fill up the oil, and it takes only once in 6 months or something. So like that, it's more patient friendly and a pocket friendly, and it is also less expensive because there is no need for repeated monitoring, especially in a rural setting. I think if Dr. Pradeep and Dr. Vijayalakshmi, they are there, or if they want to give comments, Dr. Vijayalakshmi.
Pradeep sir could not able to join, sir.
Okay, Dr. Vijayalakshmi, please, your final comments, please.
The cost or the price reduction of vildagliptin that's available to the patients now, I think like it's like having a Benz car at a very an Ambassador's price. So that kind of has made the diabetic care for the patients more pocket friendly. So therefore, in terms of long-term control for the patient, it's going to reduce the long-term morbidity and mortality and reduce the complications. So this is definitely a boon in our armamentarium against the war against diabetes, so that even patients who couldn't afford this vildagliptin earlier can be put on this molecule, and they can be able to achieve a good glycemic control without the problem of weight gain, hypoglycemia that is seen with the original sulfonylureas and all that. So this is definitely a boon in our anti-diabetic armamentarium.
I like that comment. Rolls-Royce car at Alto's price. Super.
Yeah.
Yeah.
So finally, we have come to the end point of our webinar, and we know very well an array of evidence confirms the progressive nature of early type 2 diabetes. And so it is clinically imperative that we need to get over the inertia in therapy intensification. And all have concurred that a combination therapy at the initial period itself, during the drug naive period itself, will prevent a lot of diabetic complications. And we need a therapy, a combination therapy, where it is going to be patient friendly, laboratory normalized, weight neutral, less of hypoglycemia, and pocket friendly. And that is the answer finally the patient requires for a better glycemic control. And you know very well that the market of gliptins in India, according to the AICOD, is around 3,510 crores of the total of 15,000 crores anti-diabetic drugs. And vildagliptin has 1/4 share of the total market share of gliptins. This is a recent market survey. And so it's really encouraging. See, the proof of pudding is already available, where because this molecule is very effective, the usage of molecule also has increased. So I think the future therapy holds great in the usage of vildagliptin. I thank Alkem for this opportunity, and I hand over the mic to them.
Thank you, sir. Thank you. Sir, before giving the final conclusion remark, I'd like to highlight the latest development of Glovilda. Glovilda OD is a recent addition which we have launched in the Glovilda basket with the matrix technology. And we have done a comparative trial with the parent company BD Dosage, and Glovilda OD 100 mg is DPP4 inhibition is almost similar. This is a three-month trial wherein DPP4 inhibition is almost similar, sir. So glycemic control, Glovilda OD, you can expect the same glycemic control just like parent company BD Dosage. And Glovilda OD is bioequivalent to Innovator brand as well. So this is the one data which I like to highlight, sir. Sir, it was a very nice discussion today. So we had completely covered the entire topic, not just vildagliptin, even diabetes management. There are good points which has been discussed today. And I'm sure like these points will be of great use for all the doctors who had participated in this meeting. So firstly, like to take this opportunity to thank our moderator, Dr. Sundaraman sir, for giving us this opportunity and moderating this panel discussion today. It was a very nice discussion, sir. You had completely moderated well, with given opportunity with all the panelists. Thank you, sir. I'd like to thank all the eminent panelists for giving us this opportunity and sharing your clinical experience on vildagliptin, which will be more helpful for all the doctors who participated today. And I'm sure all the doctors will be appreciating the views which has been presented by all the panelists today. Sir, at this juncture, we like to salute all the doctors and paramedicals who had contributed immensely for keeping us all safe and healthy in these challenging times. Sir, we at Alkem Laboratories will continue to serve doctors and patients by making our products available, especially our chronic bands, Glovilda, Glovilda M, Gipuros, and Volcom. Thank you, sir. Thank you all the doctors. Thanks for taking the opportunity.
Thank you. Good night. Good night.
Sundaraman sir, good night, sir.
Thank you all. Thank you all.